Good afternoon and good morning, everyone. I'm Dr. Janet Wright, and I'd like to welcome you to today's briefing, Closing Gaps Between Cardiovascular Screening and Treatment. And if I could put a little paraphrase to that title, we're talking about moving from knowing to doing. This event is brought to you today through the National Forum's Value and Access Collaborative and made possible by the support from Ardelyx, AstraZeneca, BMS, Pfizer Alliance, Novartis, and Regeneron. National Forum briefings aim to present multiple perspectives without bias on timely policy issues. Over the past several weeks, we've spoken to experts in healthcare, health systems, and patient experience. We've extended interviews with each panelist and we urge you to watch these. I cannot emphasize that enough. We have an all-star cast today, and we'll only be able to hit the highlights of the jewels that they have shared in those lengthy interviews. So please watch them, and the link to those will be put in the chat. Today, we're bringing these folks together to put different solutions on the table to identify common ground and help set an action agenda for the Value and Access Collaborative. And really for each of you has a lever to pull, actions that you can take. Solving this problem of the gap between screening and treatment will require multi-pronged solution. And if you think about it, cardiovascular disease is a systemic problem. We need systemic solutions. Today, we hope to identify one or more levers of change, especially ones that you can adopt and advance, and that this discussion, as well as the longer form interviews, will help all of us put our hands together on the key levers of change. Speaking of that all-star cast, let me introduce our speakers. Dr. Ada Stewart is a primary care physician. She's the lead provider and HIV specialist at Cooperative Health and former president of the American Academy of Family Physicians. Dr. Andreas Kalogeropoulos is a clinical and outcomes researcher in cardiovascular medicine, a special interest in heart failure at the Renaissance School of Medicine at Stony Brook University. Mr. Benjamin Bluml is the executive director of and senior vice president for research and innovation at the American Pharmacists Association Foundation. Dr. Bernadette Melnyk is the former vice president for health promotion and chief wellness officer, as well as the former dean of the College of Nursing at The Ohio State University. Dr. David Maron is the C.F. Reinberg Professor of Medicine and Chief of the Stanford Prevention Research Center at Stanford University. He's also president-elect of the National Forum's valued member and partner, the American Society for Preventive Cardiology. Mr. Doug Sousa is a patient advocate and survivor of cancer who has firsthand experience in navigating cardiovascular risk identification, preventive treatment, and long-term adherence. His perspective offers valuable insight into the role of patient engagement, communication, and shared decision-making in improving cardiovascular outcomes. Dr. Michael Cropp is a family medicine physician and the president and chief executive officer of Independent Health, a nonprofit health plan with a strong focus on population health. For more extensive background on our panelists, please visit the National Forum website. Before we hear from our panelists, here are a couple of housekeeping notes. Please utilize the Q&A function on Zoom to pose questions for our speakers, and I'll present them to the appropriate person during our latter part of our Q&A. You can also upvote these questions, so the ones that seem especially interesting to you are more urgent, and so we don't miss those. We encourage you all to use the chat function to share your perspectives and to react to the program, and reserve the Q&A for your questions. Now we're going to move into our panel lightning round, and I'm going to start with Mr. Doug Sousa. Doug, first of all, thank you for joining and bringing us your perspective. I will say, just as a reminder, we're all patients, and I ask you as you listen to Doug's experience to reflect on your own and perhaps take his advice to heart. Looking back, Doug, on your experience, what's the single most important factor that helped you move from learning about your risk into acting upon that risk?
I think it was just good communication with the right group. And that right group was, in this case, a cardiology team. I think that really gave me the right information that gave me some confidence about utilizing like a medication, like a statin in my case. But it was being able to explain that properly to me, because in the past I'd had very brief explanations about just simply you should go on the medication, but not really a clear view of how the mechanism worked. So like a good explanation of what I could expect from the medication. And I think that's the thing that really pushed me over.
Doug, we are awash. One might say we're awash these days in this world with information. We can get it on a number of devices and from a number of sources. What was it? Let's go a level deeper with that. What was it about the information that you got in the context that you received it that was that clinched the deal for you to make decisions about your care?
Well, one thing in particular, which I think is still a stigma, is that statins cause liver damage. And that stuck. And I believe in your industry, I think most patients are still hearing this message. And I think that's the clarity when I finally had a good discussion, in fact, with Dr. Maron about how people on statins don't even get, monitored at all for liver function. That was a key for me. And I think that's something that still really needs to be addressed.
If I remember, you got a prescription for a statin or in your earlier experience, and even had some imaging performed, but that information was, say, lost in translation or didn't get translated.
You wanted to go there? Yes, that's correct. So there was a delay from a scan that I had for cancer that showed that I had calcification, and it wasn't delayed to me for quite a while, number of years. And I was found out about it in my first visit with a cardiologist, and that scan came up, and the image was clear that I had severe calcification. But that was a scan that was done for a follow-up to my cancer. So that communication was lost, and I think that's also very critical. And I know some of the work that's being done now will hopefully make sure those kinds of skips don't occur.
Right.
Now
right.
it was a scan that was done years prior, and the information was there, just not forwarded to me. Let's put it that way.
Yeah. You seem to have cracked the nut on staying on treatment. That is a challenge and a struggle with many barriers for many people. Any pearls that you want to share with the rest of us on how to stick to a regimen once you're on it?
Find a good group that will explain properly and completely about your treatment and the value of it. I think I've got a good group behind me that explains an annual visit with a nurse practitioner that is very clear about even new things, and that I can learn from, and it gives me confidence to stay on my program. And she gives me a little bit of a push about doing a little extra exercise and but for the most part, because I'm stable, which is a good thing, that there isn't a lot of need to change a regimen as far as treatments and stuff.
Those are pearls. Those are definitely pearls. And I will say to everyone who's listening in the interviews, I hope you get a chance to listen to these lengthy interviews, but several themes have surfaced in many of the interviews. And one is the value of a team, a healthcare team. Another is the organic thing that goes on when shared decision making is the way we interact with each other across the healthcare spectrum. And another, I'll say, is implementation. So it's one thing to know what to do, but to actually get it done in various settings is the challenge of the day, I would say. And then finally, a financial system that supports the operation of all of those other three things. So maybe keep those in mind as we go. Thank you, Doug. I think I'll move to Dr. Maron. And I hate to uncouple you because you're quite the pair together. But the way the format works today is that we're doing sort of one-on-one. So Dr. Maron, I know you are a rabid cardiac rehab fan. And I think that is one place where team-based care and shared decision-making and a focus on prevention come together. And I wonder if you'd speak to us. Well, first, I think, well, let's go back to the imaging, cardiac imaging, and how to use that in prevention and the impact that you saw it have with Doug.
Well, in general, what we're supposed to do, according to guidelines, is assess a person's risk based on their risk factors, their blood pressure, their cholesterol, whether or not they smoke, whether or not diabetes is present, etc. But first of all, most physicians don't calculate risk scores when seeing an asymptomatic patient. And if they do, presenting a risk score is just not that motivating, or it's not that easy to understand. Your risk is such and such over the next 10 years or the next 30 years. But if you have an image, in this case, a coronary artery calcium scan, that you can show a patient their own calcified plaque in their coronary arteries that is the disease process that kills more people than anything else in this entire world. It really captures the patient's understanding. So with Doug, he had been prescribed a statin years before I met him, didn't take it. Once he understood that he has coronary disease and that it's safe to take the medication, it's a no-brainer. But so seeing the images really makes a difference.
I've had patients tell me that when they saw that image, things changed in their brains. I mean, they literally saw the image and they were a different person. So it is that expression of the image being, or the picture being, worth 1,000 words. Talk to us about the impact of shared decision making and what's necessary to do it well.
Well, for example, take someone like Doug, who had been prescribed a statin. I would start by asking, you were prescribed a statin, what led you to decide not to take it? Understanding a patient's values, what their preferences are, is the beginning of shared decision making. And it takes time to engage in a conversation like that. And generally, physicians don't have the time. So if not all of the shared decision-making process needs to be physician-patient, there is an entire team that hopefully most physicians can access. That includes nurses, nurse practitioners, physician assistants, maybe dietitians, pharmacists, maybe genetic counselors, maybe health coaches. They can all take part in the process of talking with the patient and coming up with a mutually agreeable plan.
it's the world that you paint there, or the picture that you paint there, is one where outcomes can be achieved, where health can be restored, or uh, events can be prevented. With that in mind, maybe spend a moment or two on, I know how you feel about cardiac rehabilitation, and weave those themes that we've been talking about so far together as they come together for NCR.
Well, cardiac rehabilitation is a secondary prevention program, meaning it is a program for people with established disease, typically coronary disease. And it is a great example of the healthcare team educating, motivating, supervising patients, either on site or increasingly virtually. It's a great resource for me because I can't do all of that. They are the eyes on the ground for me to escalate if there's a problem that is observed. But it's also great for the group dynamic, support from others engaging in or participating in cardiac rehab. Cardiac rehabilitation saves lives, and it's underutilized vastly. And that speaks to the problem with our healthcare system.
And the incentive structure, as we will talk about in much greater detail as we go through. Thank you so much. I'm going to move now to Dr. Stewart. I am in awe of you, Dr. Stewart, and so I feel so privileged to be able to chat with you today. Thank you for your service, and you all need to watch this interview because there is a spectrum of service that going way back. But let's say you started your career as a pharmacist and came to lead the American Academy of Family Physicians. So that's quite a sweep, and you have much to share. I'll say one takeaway I had from your comments earlier is that primary care is the foundation of prevention, sort of mission control. Say more about that and how you have seen that manifest in your career.
Yes, it's really important. And so thank you so very much for this opportunity. Primary care is the foundation. We are the first individuals to have that contact with our patients, with individuals who have conditions that can lead to cardiovascular risk, hypertension, high cholesterol, diabetes. And we have the opportunity to provide preventative measures, getting individuals into care, having the opportunity to have that shared decision making. It's so important that we, as primary care clinicians, can meet patients where they are, especially as family physicians. We're able to begin our journey with that patient, see them throughout their journey, their medical journey, and be able to be that trusted resource for individuals. And so it's so important. Again, I think about the patient that I just saw about an hour ago who came to me with a history of high blood pressure, and then did not believe that they actually had high blood pressure, and going through, that journey that they had gone through, and recognizing how they trusted me versus, unfortunately, their cardiologist. They said, I want to hear it from you, and, talk to me about what's going on. And so we have the opportunity as primary care clinicians to follow one throughout that journey. We know the family many times. We know the family history. And so it's so important. And I feel that it's a privilege to be able to have that opportunity to be part of their lives and be so important in their prevention journey.
You were eloquent on the topic, on all the topics, but on one in particular about the barrier of interoperability. And
Yes.
just in the example you gave, we think of interoperability as an electronic issue, but we're also in an environment where we need to be interoperable across professions, right? And you are in a community health center. So there are many ways to interpret that. Please speak to us about the barrier, but maybe ways to overcome those barriers in interoperability.
Yes. So, I just had a conversation again another week ago, a few weeks ago, about the fact that many of us don't talk to each other anymore. Specialists don't talk to other specialists. Primary care specialists don't talk to cardiologists. We assume information is accessible through our electronic medical records. Unfortunately, that's not always the case. We have one electronic medical record, the hospital has another, and so there is a gap as far as access to what's going on within one specialty versus another. I talk to my pharmacy colleagues as well, and we try to use that team-based care and have them help us. But if they don't have access to our patients' medical records and the prescriptions that they may be on, there could be a potential for potential harm. And so, unfortunately, in the space in which we are in right now, there is not overall interoperability across the full spectrum. For those who have been around for a long time, remember when we first thought about electronic medical records, it was so that we can have access to individuals no matter where they are. If they travel, we're transient right now. We travel from one place to another. And unless you have, the same electronic medical records, you end up missing opportunities to follow up an individual as far as, as we heard from Doug, we may not have had, the opportunity to look at, what the scan showed previously, to be able to follow up and ensure that we did not miss anything. And so it's really important that we talk to each other, that we understand that, information may not move from one place to another as we would assume that it would be.
Yes, and sometimes the information arrives at one doorstep in a form that's not easily consumed, reams and reams or pages and pages of information that, so I think we will come back to this topic of technology and the role that it might serve in actually creating time for people to do shared decision making, and how teams can help also create a few more minutes so that you can use that precious time to create more health. You have experience not only as a pharmacist and then primary care physician, but also in your current work with community health workers. Maybe, I know we're short for time, but maybe a few words about your experience there.
Yes, I have the opportunity and honor to have community health workers who work with us to make sure that we can follow up with patients once they leave the office. Again, we only have a few minutes to talk to that patient, and so they are able to be our ears and eyes within the community, bring back questions that they may have that they didn't have the opportunity to have addressed during that short patient visit. And it's really important that we use them and use them to their full capacity. They are part of the community. And so it's really important that we use them to help us to be able to gain that trust and to address all those issues and concerns that one may have as a patient that they may not be able to address at that particular time during the visit. So very important.
Amen. Thank you so much. We're going to move quickly now to Dr. Kalogeropoulos. I'm so pleased to chat with you. And again, I encourage all of you to watch the longer interview. I know you were passionate about implementation, and you highlight that scientific discovery is happening at light speed or faster, and yet focus on implementation is stuck in the mud. So tell us more about that.
Well, this is a translational gap that stems from the fact that we are in the 21st century in terms of scientific discoveries and the pace of discoveries, but our healthcare delivery systems mostly stem from the 20th century. So if you think about it, the entire thought process in the medical, like from education, for example, to the guidelines development, is mostly a thought process of a single disease. Like in reality, we have a population that is aging and living with more prevalent diseases like together, like comorbid diseases, than ever at a pace that is clearly faster than our health policies and systems can catch up. Like if you ask any primary care physician like Dr. Stewart will tell you that the complexity of the patients that are seeing right now is no match for the patients that were seeing 5 years ago because of the pace of the discoveries, diagnostic and therapeutic approaches. Patients live with multiple devices, with a lot of disease modifying and immune system modifying medications. And to develop the rapport that Ada mentioned in a 15-minute visit to understand all this and become the pivotal point for the patient's care is almost impossible. So I spent last Sunday evening with a friend who's a primary care physician, and I realized that with her schedule, it's impossible to develop the rapport we just discussed about. So this is like, you can see the gap here that the systems are built on a different thought process, but the reality is outpacing us at this point.
Yes. If I could bring a motto out of the conversation with you, it was do the math. Because you're just, it's so plain to you that the amount of time that people have and the complexity of patients and their care, it's impossible without teams. And I would also say you bring out technology. So talk to us about the swamp or the minefield of incentivizing the right versus the wrong thing.
So that has been an issue for many years, especially in the U.S. healthcare system, that the incentives are misaligned. So all the initiatives that have been designed to boost quality of care have been rather modest, and not bold enough. While in reality, what is incentivized and what the divisions, the department are looking for is procedures, numbers. So it's still, you can see that from the number of trainees that go into interventional specialties, subspecialties in my field in cardiology. Like half of our trainees goes to electrophysiology, another 25% interventional. You rarely get heart failure oriented trainees anymore. So this tells you something about the misaligned incentives. On the other hand, for a primary care physician, to make a decent salary, they have to see 20 patients for every day, 4 days, a week, cover hospital during the weekends. You see, this is a misaligned incentive. So it would be a much more much more aligned with outcome system if we were incentivizing surrogate outcomes, meaning control of blood pressure, cholesterol, weight control, diabetes control, heavily incentivized with flexible financial incentives, these intermediate outcomes. And if you want to have a real credit system where a healthcare delivery organization is incentivized for outcomes, have an idea right now. We have great models that can predict the number of events for your given primary care population over the next 5 or 10 years. So you have a number of projected events based on the current risk factors. The systems could be incentivized by getting credit for reducing the number of events. If your number of expecting events in your population that you cover is 1,000 and you manage to have only 500 heart attacks and strokes in 5 years, that could be the reason to get a lot of flexible dollars to spend to more infrastructure about that. Just to give like an idea out of the box.
Yes, and I love the ideas that you are generating. I will tease you all who have not yet watched the interviews. There is a proposal for a new societal contract. We'll call it the
that's a deeper,
Kalogeropoulos.
yes, that's a deeper thing that has to do with the previous discussion. As the population get always more and more difficult to follow up conditions, we need a new social contract. Yes, we cannot expect
Yes.
with the current healthcare delivery expenditure and resources, we cannot expect to maintain the same level of care like forever.
Yes. For more, tune in to the interview. I also am reminded to ask you all to encourage trainees and people in the early phases of their career, students, college students, to look at these interviews, because there are many ideas that are generated in them that can help people choose where they want to land and what problems they want to fix in their careers. So thank you, Andreas. We will move now to Mr. Benjamin Bluml. Hi, Ben. Thank you for joining us today. You've talked about, and you know from all of the work that you've done in your career, that medication adherence remains one of the largest barriers to treatment and to really better health outcomes. Talk to us about the effective strategies that can help people stay engaged in their treatment.
Well, in this context, over 3 decades ago, when I came to work at APHA, the industry data said that only 32 to 38% of patients would be left taking their lipid-lowering meds within 24 months of initiation. And as per the conversation here today, we know that staying on your statins and your lipid-lowering meds can actually produce improved health over time. But why is it that people stop? Well, they usually hear about the fact that they've got high cholesterol through some kind of a screening event or some type of a visit that they're having within the healthcare delivery system. The first thing that happens is that we ask them to change their behaviors and to eat differently. And after a while, they're doing things that they don't like so much, and they're eating things that they might not be that favorably inclined with. And they don't feel any different than the day before they started all of us. And so one of the key things that we've learned is that if you create a process where there's a feedback loop with the patient to help them understand their progress or the lack thereof sometimes, and you've got data, just like Dr. Maron was talking about with the calcification images, right? In the case of our Impact Hyperlipidemia initiative, we actually used a Framingham risk assessment. And one of the patient experiences that we saw there was a tailor from a small community in northern Minnesota who hadn't been doing too well with his medications for quite some time. So his pharmacist had this new program that they implemented where they got them in and they saw them on a monthly basis for the first 2 or 3 months, and then quarterly thereafter. They did a finger stick with a full lipid profile and a Framingham risk assessment to help them, stick with it. And this particular person was doing not too well until he went to the ball game the night before one of his appointments with the pharmacist, chowed down on some ballpark franks and some not very healthy food, came in the next day, and arguably it wasn't a flat fasting lipid level, but what happened is that his triglycerides were elevated very significantly, and what that produced was essentially a result in his Framingham risk assessment that he was actually 2.5 times more likely to experience a cardiovascular event. So we didn't have an image then to show them, but that day for that patient, that was when the light bulb came on. And he said to his pharmacist, "Oh my gosh, I'm not going to be here to see my granddaughter get married if I don't change." And so after years of noncompliance and not sticking with it, it was that light bulb moment for that patient. And we've got thousands of stories that we could tell as it relates to team-based care that's been implemented by pharmacists that support patients in this kind of good decision-making with ongoing monitoring and management.
beautiful to see when it works, right? When the system
Amen.
delivers. Yes, indeed. So you've also weighed in on the problem of interoperability as it relates to medication management. Shed some light for us there.
So, well, one of the things that we believe is that the seamless flow of information between and among all the members of the healthcare team is absolutely essential. And when you think about the primary treatment modality for chronic conditions in our healthcare delivery system today, they're medications, right? And but one of the huge challenges that we have is related to the fact of I suspect we could go around the table here and share experiences of all of the dysfunction in our healthcare delivery system associated with just one simple idea. Does the patient have an accurate, up-to-date list that gets shared with each healthcare professional they visit with on the team? And as easy as that sounds, that does really hard. And so we're really excited today with technology evolution that we've got the new TEFCA framework. So the Trusted Exchange Framework and Common Agreement that's out there. The Office of the National Coordinator announced just a couple of weeks ago that they've now reached a place where they've got over 1 billion transactions that have flowed through the system. But imagine that you could engage your pharmacist and imagine that that pharmacist was helping to contribute to that shared record, an accurate, up-to-date list for each patient's meds at least once a year, if not multiple times a year. And the entire healthcare team had an organized way to navigate with that. What could that do to actually improve people's lives? We know that it's huge because we know that when you look at the research out there, and there's plenty of it, but the most recent research that we've seen basically shows that for every dollar we spend in the United States on a medication, we're spending $1.55 on misadventuring associated with that medication. Now, what implication does that have economically? That might not seem like a lot of money, but if you do the math on it for 2025, that means the United States alone is spending over $1.076 trillion a year on medication misadventuring. And so if we could just get their medication lists right as a starter to the team-based care, we'd be in great shape. And I think the other thing I wanted to add to Andreas's commentary on the incentives, we have this motto we've used for several decades that goes, align the incentives, improve the outcomes, control the costs. And those incentive alignments, if you get them right, first and foremost for the patient, and then for all of the providers on the healthcare team who are actually participating in this team-based care, and if you get it right for the payers. So for those three audiences, if we do that, what we know can happen is that for those payers who have the courage to change the way that care is being paid for and delivered, they too can spend less in total, and we can dramatically improve our patients' quality of life.
Well said, Ben. Thank you. And thank you. Please keep doing what you're doing. Bern, we will move to you, Dr. Melnyk. The nut to crack, Bern, is behavior change. Say more.
Most people, unfortunately, don't change unless crisis happens or their emotions are raised. That goes for clinicians too. Behavior change is what I call character building, right? And I want to reiterate the story of Doug and Ben. We've got to help people emotionally face their true story and rewrite a new one. Myself, it took my cardiologist showing me my scan for my coronary artery calcium scan to get me to start my statin. And again, through motivational interviewing, through different types of strategies. We know what works, but bottom line formula for me, when I work with patients, it's always the formula of the evidence plus emotion that gets people to spark change.
And lasting change, right? That's another element in being able to adhere to healthier practices and habits. Yes. Bern, you have a long career in education of nurses, inspiration of everyone else, and nurses are central to cardiovascular prevention and really health in all aspects. Talk about the role of nurses, let's say, with hypertension.
Nurses are huge. They're a huge key to improving cardiovascular outcomes. We are educated and skilled to work with people on behavior change, whether it's lifestyle modification, whether it's adherence to medication. And I can't emphasize enough about the power of story. The stories we tell ourselves are incredibly powerful. We've got to help people to face those true stories with emotion and rewrite new ones. Without doing that, people aren't likely to change because we bombard people with information overload. So unless we start pulling in emotional story, I want to live to see my granddaughter's wedding, whatever it is. If we don't get to emotion, people are going to keep probably doing what they've always done. The other thing I want to point out is micro changes. Often people set these huge, hairy, ambitious goals on January 1, and then they fall off the wagon by January 30th. So micro change, because inch by inch, it's a cinch. Yard by yard, it's hard.
Beautiful, Bern. This is impossible, but in a minute, talk about the thread of emotion as it relates to and plays into burnout. And I think burnout, we think about it for clinicians and we've seen it and it's scary and it needs to be addressed, but there's burnout in the population in terms of health behaviors and behavior change. So speak to us briefly about burnout. Remedies for burnout.
Yes, 40 to 60% of clinicians are still burnt out. We had a mental health pandemic prior to COVID-19. It escalated during the pandemic. People thought it would recede after the pandemic. It hasn't. Think about what we spend on clinician burnout. It is tremendous. When clinicians are burnt out, they can't be fully engaged. They're in cognitive overload. We know clinician burnout adversely affects quality and safety of care. Clinicians don't want to hear from healthcare administrators, you need to be more resilient. Clinicians are resilient. What they need is for system problems to be fixed. And that goes back to healthcare executives to do that.
Thanks, Bern. Back to system solutions for system problems and conditions. Thank you. Dr. Michael Cropp, you're going to send us across the finish line here. It is really, you're an inspirational leader, and what you've done at Independent Health, there's so many lessons for other places in the country and pearls that you can share. So talk to us about the greatest, well, actually one thing I want to bring out from your interview that I'm going to be chewing on for quite some time is this idea of trust. And Stephen Covey's talked about it. Change happens at the speed of trust. I'd say health happens at the speed of trust, but you have a great example of that there in Buffalo. Talk to us about trust.
Sure. Thanks, Janet, and appreciate the opportunity to build upon this great dialogue. So when we started to look at outcomes and quality, one of the things that we did was we sat down with our physician partners and picked a couple of conditions, diabetes for adults and asthma for kids, and said, tell us what excellence looks like. And they did. We defined it. And then we went back and said, okay, if this is what excellence looks like, we'll develop a scoring mechanism, 10-point scoring mechanism, 6 for outcomes, 4 for process. And you guys tell us that this is what excellence looks like, and you do it all the time, but we're going to give you this score sheet to go back and audit your own practice. And when they did, it was eye-opening. So instead of our going in and looking at the practice, they were blown away by how infrequently they were actually following what they said was excellence in care. And when we sort of began to publish that data amongst practices, physicians are highly competitive. And all of a sudden, the wheels started to turn. But that was a huge trust building exercise, which then followed on by continuing conversations with the primary care docs about the challenges that they were experiencing. And they were saying that we don't have time to have these conversations with patients to understand what's important in their lives. Seeing 25 to 30 patients a day, it doesn't work. And, team-based care, the mechanisms aren't there to reimburse for that. And who is paying for excellence in prevention? So we sat down with them and over 9 months said, okay, let's do things differently. And we came up with a new model for providing care that took a whole different approach to revenue. So up front, there was a case mix adjusted payment that went to practices that they could then choose to pay nurses, pay embedded pharmacists, pay behavioral health specialists, pay physical therapists, depending on the culture of their practice, in ways that they knew would make a difference, but hadn't been reimbursed before. And then we continued to pay fees for the services that in the literature we knew made a difference. The post-hospitalization follow-up visit, the enhanced annual visit. You get what you pay for, incentivize those things that you want to happen more often. And then at the back end, again, a case mix adjusted budget. And as was indicated before, they got rewarded for excellence in care. And so making sure that we were giving them the information that they needed to understand how well are they doing in controlling their patients' blood pressure, their diabetes, their cholesterol, rewarding them for that. And they also got rewarded for doing that work that prevented the hospitalizations that were avoidable. And it was a model that we co-developed and co-owned. And that made such a huge difference. And that was the foundation for the trust that has enabled us to continue to really turn to our practice partners to innovate and to modify this as we go to make sure that we're still driving for those kinds of results. And we've been fortunate in terms of achieving rates of control of blood pressure, diabetes, and lipids that are pretty substantial.
Mike, it makes such sense to me. And if I could, I'd posit that what you did was share decision-making with your primary care workforce from the beginning. And so it's a great example of how you took a practice and applied it to a different area. So congratulations. And I think that's a great take-home point for all of us. I wonder if you'd speak to how you've used technology within independent health. Again,
sure.
This is you could give several days seminar on this, but a short answer.
So one of the cool things that happened is once we got better diabetes control with the adult practitioners or the primary care docs who were seeing adults, they got to a point they said, hey, we're doing everything within our control. Our patients need help. And so we came upon some technology that we've been using since then called Brook, which is a very sort of first generation machine learning capability where people can use their telephones and there's a lot of ambient information that's your phone's collecting about you, your sleep, your physical activity. And, you know, you can input so many other things now. And if you have that capability and you can connect it to a database and then use a conversational user interface to interact with the patient, all of a sudden, information that they couldn't think about talking to their doctor about, like I'm in the grocery store and I'm looking at a protein bar. Which one's the best one for me with diabetes? It's there in their hand. They wake up in the morning, they didn't sleep well. Your blood sugar is going to be a little bit higher. Well, your phone knows that you take a walk in the morning for 15 minutes. Well, maybe today it's a 30-minute walk. So, you know, technology now is able to meet the patient where they are, and our ability to collect that information in aggregate and have the trends and the correlations delivered to the patient. And then the patient can email it to the doc so that at the quarterly visit about diabetes, the doc can see that, wow, those days when you walk 7,000 steps or more, your blood sugar is better. Let's work on that for the next quarter.
Talk about a patient empowerment tool that's also working for the clinical side. Yeah,
exactly.
Yeah.
And it aligns the interests of the doc and the patient, because we're rewarding the doc for better control. And now we're giving the patient some tools that they can use in the moment. And then it enables the right conversation when the doc is there. And the care model that we've developed allows the docs to be able to do well seeing 12 to 15 patients a day. So they can have the conversations and understand what's important to this patient. And now let's talk about what you can be doing differently that will help you achieve the outcome that you're looking for.
And it's timely, which is so key, not to let it drift. With chronic conditions that drift, we get into all manner of trouble. So awesome example. I cannot believe this time has flown, but it has, and I'm not doing the greatest job in monitoring the time because I get lost in the conversation. There is a question that was sent in through the Q&A box that's so incredibly important. I'm grateful to whoever posted this. How can public, so I'm throwing this to the group, but keep in mind, you need to be a mini answer. How can public health professionals who are not in direct clinical care join the conversation with patients or people to support shared decision-making when it comes to cardiovascular health? So the role of public health professionals.
Can I take this on?
Please, Andreas.
I think the most important concept that public health professionals can disseminate, the most important message that they can disseminate is that even small improvements in your risk factors, small improvements can have a huge impact on your own health and the health at the population level and make a huge impact on the society. Because that's more difficult, like for a patient to appreciate, to translate the science, the trials, whatever we have, like what it means like for their own life.
Anyone else like to weigh in on that question? All right. Well, we'll close with a lightning round, and I'm challenging you all. We've got 30 seconds or less for the answer to your question. What's the single most important action healthcare leaders, policymakers, clinicians, or patients, people, should take to improve the transition from screening to treatment, from knowing to doing? Dr. Stewart, leadoff hitter.
Oh my goodness. I can think of a couple of different things, but one, as a family physician and primary care specialist, more money needs to be spent on primary care. We are the foundation for prevention. More money on primary care, we will definitely see better outcomes. And so I'm going to stick with that. Thank you.
Thank you. Andreas.
Well, the one most important thing is to align financial incentives with prevention and the results of prevention.
Thank you, and concise. Ben.
Well, one of the challenges we have is that pharmacists are not named as providers in the Social Security Act. We know from pre-pandemic data a couple of years before that over the entire count of the U.S. population passes through the front doors of a community pharmacy every 8 days in this country. So if you want to put the pharmacist on the team officially, the Main Street Pharmacy Access Act would be a good process start to do that.
Thank you. Bern.
Let's not continue to take 15 years to translate evidence and evidence-based guidelines in the practice. Take one of our new recommendations and act with urgency to implement it today.
Thank you, Bern. David.
Big picture, the biggest barrier is our fee-for-service healthcare system method of reimbursement. We need to reimburse for outcomes, for period.
P for O. I got it. Doug.
Yeah, after hearing this conversation, I feel very fortunate. I have a very good primary care physician. And so my recommendations to patients is find somebody you trust, which was mentioned today, and somebody who's current and willing to bring you forward to other specialists if necessary.
Thank you, Doug. Bring us home, Mike.
I would say CMS and state departments of health for the populations they cover ought to tie the reimbursements that come from the federal government and the state government to the accountable entities to better performance in terms of managing the risk factors of heart disease. Put dollars at risk.
Speaking of risk, yes, that's a great way to close out the conversation. So let me first thank all of you panelists who have joined us and spent time on a really in-depth interviews, sharing your wisdom and your experience with us and with everyone who's gathered today. I also want to thank the forum for gathering these experts and for running this Value and Access Collaborative. On behalf of the forum, I again want to thank our sponsors that are listed here who've invested in this conversation, this dialogue that is generating solutions and helping to drive implementation of those solutions. So thank you all. We look forward to continuing the dialogue together. And please, again, visit the interviews on the website and put those actions into play where you live and work. Thank you so much.